My dear friends, in this video I shall demonstrate to you how I performed direct phaco chop in a patient who had a YAG peripheral iridotomy and a moderately dilated pupil. This is how the eye looked under the operating microscope. The anterior chamber was shallow. There was a peripheral iridotomy. You can see the retinal illumination. And the pupil size was around 4.5 to 5 millimeters. So I started off by staining the anterior capsule with trypan blue, created the clear corneal incision at my usual location of about 120 degrees using the corneal pocket incision as counter traction. As usual, I wash out all the trypan blue before insufflating the anterior chamber with viscoelastic. The capsulorhexis is then initiated, and I'm trying to aim for at least a 4.5 millimeter capsulorhexis size. Well, the capsulorhexis goes on without a hitch, and I managed to successfully complete it. The next step is hydrodissection, so cortical cleavage hydrodissection. You can see the fluid wave pass onto the other side. The center of the lens is then gently depressed. I use the rocking motion of the lens to help me decide whether this nucleus will rotate or not. During the insufflation of viscoelastic, I check for rotation. In most cases, I'm able to succeed in noting if this nucleus will rotate. The phacoemulsification by the direct chop method is then carried out. The settings in this case is use of pulse phaco, power of around 40%, because this is a grade 2 nucleosclerotic cataract. So bury the phaco tip just proximal to the midpoint, initiate the crack, and then using the paddle maneuver, I separate the pieces. Quickly rotate the nucleus, create another chop and separation using the same techniques. Because the pupil is small and the capsulorhexis size is also a little small, I aim for multiple pieces, definitely more than 6 pieces. I do not remove the piece from the capsular bag till I have completed all the chop maneuvers. So once I feel that I have broken the nucleus into sufficiently small pieces to be emulsified, the fragment removal and the mobilization of nuclear fragments is then carried out. The beauty about the phaco chop procedure is that you can use the same settings to initiate the chop as well as for fragment removal. So the same vacuum of 350 millimeters of mercury is used. This is a Stellaris machine, so I do not set the flow rate. A power of around 40% and a pulse phaco mode. While rotating the nucleus pieces with a sharp chopper, make sure that you use the blunt end of the chopper to rotate the pieces. Of course, it's much easier at this point once you've created the cracks and you've successfully created the separation. It is a much better idea to switch over to a Sinskey hook, which is what I would strongly recommend. But in this particular case, I'm in a flow and I just continue performing it by simply orienting the side port instrument, which is my sharp chopper, horizontally to keep it out of harm's way. So in less than a couple of minutes, the entire nucleus emulsification is over. The cortical aspiration is performed using a coaxial IA, which is also my instrument of choice for cortical aspiration, because I feel that the sleeve around the coaxial IA gives you a very snug fit at the incision site and helps to keep a very well maintained anterior chamber. Getting at subincisional cortex can be mastered by learning to roll your wrist, because the tip of the coaxial IA is blunt and the aspiration port is about 1.5 millimeters away from the tip. So even if you face it posteriorly, it will not damage the posterior capsule. While insufflating the anterior chamber with visco, make sure that you put more visco anterior to the iris than behind, because if you do so, it will cause an iris to prolapse. The intraocular lens is then carefully injected so that in one shot you're able to clear the edge of the iris and drop the lens directly into the capsular bag. It's important to remove all the viscoelastic from the eye to prevent postoperative spikes in the intraocular pressure, and I therefore go behind the lens by lifting one of the edge of the optic. I rotate it. I call this segmental removal of viscoelastic. So I remove viscoelastic from all segments of the posterior chamber. The viscoelastic is thoroughly washed out from the anterior chamber, and using a bud compression technique, I get to seal the wound. Well, one of the indications that the bud compression technique would work is if you see a slight amount of hydration at the incision site. If you can see the sign, then you know for sure that the bud compression or the bud out technique will definitely work. And finally, moxiflox is injected into the anterior chamber. I thank you for your attention.